every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
Okay, let's get started here. Okay, today I'm going to be using some of the videos of our patients and through the voices of our colleagues, I'm going to try and bring to you not just something that I'm passionate about, but what I think is becoming increasingly relevant in our area of emergency medicine practice. So here, the outline. The need. I hope to show all of you not just why there is this need, but how we can shift gears from our resuscitative approach to that of a palliative care approach when that's what our patients really need. Okay, the barriers. There are many barriers, but I think the biggest barrier, as Noreen actually pointed out, is the mindset. And thirdly, the initiatives, how we at NUH-EMD have embraced end-of-life care. Okay, we'll start with Dr. Shahnaz, the very charming Dr. Shahnaz, and I'm looking at Ian. Don't be jealous. You're quite charming too. Okay.
Well, the practice of emergency medicine, working in the ED is like akin to working in a war zone, some would say. It's busy, crowded, lots of patients, but you know what? Every day is a roller coaster ride, and you know, you go in with the mentality that you want to change someone's life or save a life, and it is definitely a fulfilling job. It's not for the faint-hearted, but at the end of the day, you can give yourself a pat on the back and say you've done a good job.
Okay, so that's a very traditional but very prevalent view to emergency medicine. We hope we save lives, and that's what we like to do. Okay, but, okay, let me show you some of our typical patients that actually benefit from our aggressive resuscitative approach. Let's get started.
This is to control. Message received loud and clear. Roger out. Dr. Khalid, this is standby trauma. EK 1 2 minutes over.
Okay.
This is standby trauma. EK 1 2. Fall from height. Can we stand by the trauma team, please?
Okay, noted.
Standby trauma team.
Let's prepare the airway, okay? The tubes.
So you have the young polytrauma, and at the same time we have the 60-year-old man that had a cardiac arrest at the nearby coffee shop.
No, not Shakabrida. AC Stali all the way.
And then we have the very dramatic patient in pain.
Okay, doctor, 9 p.m. patient found conscious. He was complaining of severe abdominal pain.
My left side, please. No, be gentle, please.
Blanket, yeah. Okay, sorry.
Goodness, it really hurts. Really, I
Okay,
cannot.
okay, can you tell me your name?
How many times you want me to tell you my name?
Yes, I
It
understand.
hurts. Please,
Okay.
just help me now.
Okay, like,
Okay,
pull it back.
can you tell me exactly where you are feeling pain?
It's my lower left side.
Okay, we are going to shift
Where's
you
your
over.
pet slide?
Yeah, we're going to shift you over.
Okay, looks familiar, yeah? But then, as often as that, I think we see the very elderly, like this patient here, and some have very advanced chronic illnesses, some have very poor functional states, and they present to us with severe acute illness. For these patients, right, does our standard resuscitative approach suffice? Let's look at this patient.
Currently BP still 61 over 31.
Okay. How much drip has gone in?
Drip? Okay.
No drip because no lines.
No fever, right? Using the PET slide. Yeah. Okay. Then no fever 36.5, hypercount is 9.6.
Auntie, Sasing,
Patient heart problem, no other medical problem, usually can walk and can talk. She speaks English.
Auntie, how are you?
Yeah, so multiple attempts at IV cannulation, BPs like that. Patient's very old, the veins are frail, small, frail veins, and there's peripheral shutdown because there's hypotension. So the senior doctor starts putting in a neckline while the rest of the team is preparing to put in the tibial IO line.
got a history from the family. The daughter-in-law as well as the grandchildren outside. Actually, she stays with the maid as well as her own daughter, but the daughter is overseas. So has been with the maid for the past week as well till 6 p.m. today. When she suddenly, she was lying down and then they noticed that she had cyanosis. Other than that, has been well recently, no fever, no diarrhea.
Okay, so we have a very elderly 90-year-old with severe hypotension, and then we find out piecemeal, but she's got a history of dementia, she's got chronic kidney disease, as well as other chronic comorbidities, and she comes to us with in this crisis state. We get into our default resuscitative mode. So this lady gets the full septic workup, gets labs, gets lactates, gets gases, blood gases, gets the chest X-ray, the ECG, bedside ultrasound, and a CT head, which is normal, and then IV fluid boluses, and then IV dopamine. And then we think, oh no, pulmonary embolism. Now she needs a CT angiogram, but no, CKD, nephrotoxicity, oh no. And then we begin to realize that, wait a minute, this is a very ill patient, and the likelihood of survival is very poor. She's got very poor prognosis. So what do we do now? So I think it's important that we start engaging families as early as possible for these patients. Fortunately for this lady, she had a very cohesive family, and they were very clear about the goals of care for this patient because she had had this discussion with them previously. So we decided that it's time to shift to a palliative approach. We transferred this patient to our quiet room. We allowed the family in, and she died 8 hours later in our emergency department. So, what have we achieved by shifting gears? I think for the patient, it meant experiencing a good death, or maybe at least a better one. The family being reassured that, they're doing the best for the patient, they're doing the right thing and are supported. For the ED team is the knowledge that, we are delivering quality end-of-life care for this patient. And for the hospital, maybe better allocation of resources, because ICU beds saved, cost saved, and without compromising quality of care. What about for the EM specialty? I think it means expanding our skill sets and adapting to the new needs of our society. Okay, a little bit of ED data here. I always find this interesting. So we talked about the 400 deaths a year, but we looked at other P1 diagnoses, and AMIs occur at almost the same frequency, right? But we are pretty good at managing that, right? What about asthma and anaphylaxis? Double-digit numbers. And we pride ourselves on being experts for that, right? What about delivery? It's not very common, but we had 5 that year. And don't you recall attending specific teaching sessions on how to deliver a baby? But has your department, or have you attended sessions on how to manage the dying? So here we have the very lovely APN Geraldine, who will talk to us about the various protocols we have.
In the emergency department, to provide the best quality of care, we utilize protocols and guidelines for treatments such as MI protocols, trauma protocols, stroke protocols. Then we have patients who are actively dying. Our EMD sees at least 1 death a day. It is very important that we as healthcare providers are better trained at managing this reality. Usually we focus on aggressive treatment. When those managements become futile, or if the patient and family chooses comfort care, then it is the moment that calls for intensive caring and symptoms control.
So does your department have a protocol for managing the dying? Okay, barriers. Now we've got the very cool Dr. Keith, who will tell you about barriers.
Yeah, some of the problems we face are time. There are many demands on our time. We have to see patients, we have to deal with relatives, and sometimes it's difficult to devote time specifically for palliation. At the same time, we have a problem with space. First, there's a hospital access block where our patients stay in the ED for up to a day, so we may not have a conducive environment for patients to be, for palliative care to be effected in the emergency department. At the same time, our training also generally focuses on resuscitative care and not specifically on palliative care. So we try to treat and find things that we can heal.
So pretty good for a post-night interview, right? Okay. So Keith talked about access block, and I'll show you why. This is what he left us with that shift. An overcrowded lodger ward, patients waiting for beds, corridor beds. So not something we are unfamiliar with. Okay, and then we've got another unique one, restricted visitation. Somewhat goes against the family and patient family-centered approach of palliative care. We'll talk about that. Okay, just as much as there are barriers, there are solutions. None of us have had any really formal training, but times have changed, and Dr. Bang will talk about educational opportunities later on. Our culture, we often are fast-paced, we love interventions, but we need to slow down for these patients, we need to focus on communications and invest time in that so that we can save time later on with futile interventions. The environment, private space is what we will need. Not everyone has the luxury of a room, but even a space that can be cordoned off with curtains will be useful for families. Resources, always limited, but by this I mean limited information, access to information. For example, being able to call the primary physician or get MSW support, especially if this is in the middle of the night. But if we are well versed with palliative care approach, we'll have some tools to manage these patients better. Okay, I think the biggest barrier is still that of our own mindsets. And I say this, I'm sure we have said some of these things before because I have. This is not my problem. The primary doctor should have had this discussion a long time ago. I don't have time to discuss patient preferences. I'll just do what I've been taught to do, the standard stuff. Let the inpatient team deal with it later on. I have no previous rapport with this patient. It is just too emotionally draining to handle dying. If I don't do everything to save this patient, then I have failed. Okay? But I think we could look at it from a different perspective. I think acute crisis events are an opportunity to help these patients and families make decisions. Sometimes they've avoided doing so before. And I think emergency physicians and nurses, we have a more objective overview of the patient's issues because we don't have that pre-established relationship with these patients. And ED staffs, I think we can serve as advocates for the patient's goals of care. And by this, I mean that we can help to coordinate care between the different inpatient specialties, between the interventionist, between the PAL care specialist and the family. Noreen actually already alluded to this earlier. I think we have certain strengths that already help us to manage these patients in crisis situations. And lastly, I think that ED is like a staging area. And what we decide to do in ED actually sets the course for this patient's subsequent journey. Let me just explain this point a bit further. Okay, I think the communications that we have with patients and caregivers about the illnesses, the goals of care, and the treatment options then determine the degree of our medical interventions. Do we start vasopressors? Do we intubate? And that determines the subsequent site of care. So can these patients go home, be terminally discharged? Do they go to ICU? Do they go to general ward? So what are some of our initiatives? We started end-of-life care about 2 years ago in our ED, and we've had to overcome a number of barriers. But we started with a team, and we formed a work group with doctors, emergency physicians, emergency nurses, and even a representative from the operations side. And with this team, we have established clinical guidelines and educational activities for the whole department. Okay, I will let Jessica tell you a little bit about our quiet room.
There are many sick patients in the emergency department every day, and some of these patients are not for active resuscitation, but we still need to care for them and support their family member through their difficult time. So despite space constraint in the emergency department, we have tried to set aside a quiet room for these sick patients during their last hour. This is our quiet room where the family members can be with their sick loved one during their final hours.
Okay, I can say, the room is really small, but we've been quite blessed to have this space. But more important than the hardware, the flowers, the butterflies, is actually the software, the care that the nurses and the doctors can provide these patients, the empathy, the communication skills, the symptom recognition and management of these terminal symptoms. Our experience managing the imminently dying, because we've, in the last year and a half, developed these guidelines to help us to recognize these patients. And we've decided to focus on the imminently dying, for whom we can actually make a difference in their last hours. So we managed about 130 of these patients in the last 15 months. That's about 8 to 9 patients a month. 30% of these patients died in the ED. 4 terminal discharges from our ED, and 14 patients were terminally extubated at the ED. The median length of stay was about at least 8 hours, but I think 12% stayed more than 12 hours in the ED. So the rest of them went to the ward. Majority of them passed on in the ward. A few were discharged home or to the hospice and died later on. So in closing, embracing end-of-life care in the ED, I think it's important because the need is there and these are our patients. I think we have a unique opportunity to make a difference. We already possess some basic skill sets to deal with these crisis situations, and we can enhance this by adopting palliative care principles and adapting them to our emergency medicine practice. We can change mindsets and overcome these barriers. I think ultimately what we want to do is provide the kind of care that we would want for our own loved ones. Let me leave you with this final quote that I find interesting. Okay, it sort of describes the journey that we have faced in establishing end-of-life care. All truth passes through 3 stages. First, it is ridiculed, and I must say I wasn't openly ridiculed, although I heard the word oxymoron many times. Then it is, secondly, violently opposed. I don't think I received violent opposition, but maybe some silent, subtle ones. Third, it is accepted as being self-evident. And that's where I hope we are at today. Thank you.